Welcome again, our colleagues, in our fifth session. It will be today CNS Viva hot seats. We have more than 40 cases. Hopefully, we can finish them. Candidate number one, 10 years old
Yes,
male
sir.
patient. 10 years old male patient complaining of vision and hearing loss. Go on.
I'm provided with coronal T2 MR images of a 10-year-old male patient who has presented with vision loss, and I can see T2-weighted hyperintensity in bilateral temporal lobes. Can I see the axial, sir? It is extending from the occipital and parietal region and extending down into the brain stem in the region of the tracts. And can I see T1, sir?
No T1.
Okay.
He is just T2.
Okay, so in a 10 years old with the white matter bilateral symmetrical hyperintensities extending up to the subcortical region, I would first think of a leukodystrophy. And since
Yes.
it is occipital predominance and with extending towards the frontal area, occipitofrontal progress,
Yeah.
this may be adrenoleukodystrophy in a 10 years old.
Excellent. Excellent. This is the post
Uh,
contrast.
There is advancing edge of enhancement in post-contrast T1 images, which further confirm my findings of adrenoleukodystrophy. I would like to screen this patient for any adrenal dysfunction, and I would convey my finding to the referring physician for genetic screening and metabolic profiles
Excellent.
and further
How many
management.
layers are seen in this pathology?
Layers of enhancement.
Not enhancing. In the pathology of this disease, it looks like multiple layer. Could you know how many layers?
Uh, uh, I cannot. mm,
Okay. What could you
Understand
tell
your
me?
question.
Mm, yeah. Could you tell me what is the pathology of this disease?
So this is
What is the etiology?
X-linked. This is X-linked disorder, autosome X-linked disorder, which
Excellent.
is
What?
seen in boys only.
Okay. Excellent. What happened? X-linked
Uh,
autosomal disease. What happened in this disease? What
uh,
is the
so
pathology?
I cannot recall appropriately, but there is some enzyme deficiency, I think,
Excellent.
in
Result in accumulation of something in the brain.
lysosomes accumulate in the brain. I think I'm not sure.
Excellent. No problem. No, don't worry.
Mhm. Mhm.
Case number 2 for candidate 1. I think we finish this case. This is
Yes,
the same case. Okay.
same case.
25 years old female patient. Sorry. Have numbness, tingling, and headache.
Um, this is the sagittal T2 weighted MR of the cervical spine. The
Yes.
cervical vertebra appear unremarkable with intervening disc space is maintained. The cervical cord shows a vaguely defined hyperintensity in the dorsal aspect of the cord, just at the level of 1, 2,
Excellent.
3, 4 cervical
Which
vertebra.
sequence? Which
I
sequence you
want to
wanted
see
to see? Hmm.
axial T1 with contrast.
Axial T1. No, before contrast. You wanted to see something
Uh, s-
else?
Sir, T2 fat sat axial or stir
Yes.
images. Mhm. In stir, I can see there is hyperintensity more visible on the posterior aspect of the cervical cord. There is not much gross expansion of the cord at this level, and this is partially involving the cord in a triangular configuration. Less than a hemisection of the cord is involved, and a small segment of the cord is involved. And this is likely
Give me differential, please. Differential. What's your
transfer,
differential?
sir. Sir, it can be involvement by multiple sclerosis. It can be involvement by neuromyelitis optica or transverse myelitis. These are the differentials for this sort of involvement of the
What
cord.
is your
It
next
can be
step? Your next
Sir, I
step.
would like to screen whole of the neurexis to see any other concomitant lesions, and I would like to see in the previous imaging if available and correlate this with the history of the patient. And I would like to see if in the CSF there are any oligoclonal bands. I would like to inquire about them, which would further confirm that this is going towards MS. And I would like to ask the history of any relapsing remitting illnesses which would further direct the case towards multiple sclerosis. And
Thank you. I think 6 minutes finish.
Yes, sir. Time is up.
Thank you. Thank you. Thank you,
thank
candidate one. You did very well.
thank you.
I will give you the highest mark in both cases. You are confident. You are logic. The most important point today, you are very logic and you are smooth. You give me step by step without asking you. This is very good. See, my colleagues, this is abnormal signal here. You did one wrong mistake when you ask after T2 post contrast. No, sagittal stare first. Ask for stare. Please, my colleague, mute yourself, please. And to confirm the bright signal. Why? Because it may be here some pulsation. So after stare, it is very prominent. Look down. All of this are pulsation or artifact. All of these are artifact. But here, this is the pathology. Short segment. When we see here, affecting mainly the posterior part of the cervical spinal cord. So our differential diagnosis should be first MS, second, and less likely transverse myelitis because transverse myelitis is more longer and there are expansion of the cord. Next step, as you mentioned, very good, you will do a brain MRI. My colleague, please mute yourself. Please, my colleague.
मेरा उठा
Are
बच्चे पीछे
some
इसमें अलमारी में पड़े हैं ये भी पड़ा है ब्राउन सा वो मैच तो नहीं
let's continue our session. Case number one, startup case. Looks like difficult case, but you smashed the case very well. Bilateral symmetrical butterfly, mainly posterior. Signal abnormality white in young age. Posterior means adrenoleukodystrophy. Very good, Doctora, first candidate. But I ask you a more question to give you the full mark. This is a adrenoleukodystrophy caused by the accumulation of long chain fatty acid within the white matter and suprarenal gland due to enzymes abnormality, X-linked, as you said. This is the enhancement of the middle layer. The disease is consisted of three layers. Okay, this is the middle one. Why? Because here there are a brain blood barrier destruction, so it is enhanced. So I ask about this. I know this is may be out sometimes of our scope, but the examiner can ask to give you the highest mark. Candidate 2, are you ready?
Yes, sir, I'm here.
Sir, Dr. Roshni.
Dr. Roshni, welcome.
Thank you, sir.
Welcome our star. Because you are our star,
No, sir.
I will give you a very good case. Okay?
Yes, sir.
30-year-old female patient, medically free patient presented with a decreased level of consciousness and an acute confusional state.
Okay, I have been provided with axial CT images of a brain of a patient who is presented with the complaint of acute confusional state and altered consciousness. So in this, I can see that there is an evidence of hypodensity noted within the region of the left temporal lobe. Um, it is causing the effacement of the sulci and the gare and a mild mass effect, and there is a relative sparing of the cortices, and the ventricular system appears normal in this patient. There is no any other abnormality noted within this. So in okay, there is hyperdensity, and soft tissue mucosal thickening is also noted within the bilateral maxillary sinus. um, so in this patient I am thinking of temporal lobe encephalitis. Other differential for this can be infarct, but least likely. However, in my routine practice, I will look at the post-contrast images. And
Contrast.
sorry,
Do you want to see something else in this CT?
yes, I would like to see the bone window to see if there is any evidence of fracture or.
Excellent. This is the one window.
Here I can see these are the axial images of the bone window. Here I can see there is an opacification of the mastoid air cells and the middle ear cavity. So this suggests of otomastoiditis, which have lead to I think temporal lobe encephalitis. So in this patient, I will also look the sinuses, venous sinuses. There is evidence of venous sinus thrombosis in this patient, and
Excellent. What else?
all. On the also look the venous signs, and there is no any evidence of hydrocephalus in this patient. There is a maxillary sinus opacification. This could suggest a maxillary sinusitis in this
What is your
patient.
next step?
I will immediately convey my finding to the referring physician and refer this patient to the neurology MDT for
Before referring, the patient is in your department.
IV contrast images.
No need for contrast image. What would it add? Do you want to do something else?
Uh, okay, in the MRI brain.
Yes.
Okay. I've been provided with axial T2 weighted images of a brain. Here I can see that there is an evidence of hyperintense signals are noted within the left temporal lobe, also within the left mastoid air cells. Um, and there is a mild adjacent edema is noted. Uh, the rest of the brain panorama appears unremarkable. Um, I would like to see the DWI images and ADC images in this patient to see if there is any evidence of diffusion restriction. Um, Okay, here I can see that there is evidence of gyriform hyperintense signals are noted, which is showing that I will confirm on the ATC images. And there is a diffusion restriction also noted within the left maxillary sinus, which likely suggests a maxillary sinusitis. So this patient require referral to the ENT department uh, for uh, for sinusitis management, and also require referral to the neurosurgical MDT for antibiotic treatments and.
Do you want to check something else in this post-contrast?
Post contrast and
Ask
MR
me,
vein
please, to give you.
I would like to
Ask.
see the post contrast images.
This is a post-contrast.
Okay, I have been provided with the axial post contrast images of a brain. Here I would like to see there is a mild enhancement is noted in this region, and also I would like to see the transverse sinuses in this patient. Uh, the left transverse sinus, there is a filling defect is noted in the left transverse sinus, which suggests that there is an evidence of a left transverse sinus thrombosis in this patient.
Include. What's your
1 minute left.
Okay. What's your diagnosis, please?
The diagnosis is left temporal lobe encephalitis with maxillary sinusitis and left transverse sinus thrombosis and automastoiditis.
Do you expect the restriction in encephalitis? This is. Do you expect in encephalitis this restriction? Try to connect this with this sinus, please.
Okay, so
You
this
are
is
very
the temporal lobe
Hmm.
infarction.
Yes, yes. Could you tell me what type of infection? This is very critical, Dr. Roshni. Look here, please, and tell me. The key is here. Very important. Here, what type of infection? What type of
Fungal
sinusitis here?
infection, okay. Fungal
Yes,
sinusitis.
yes. Thank you, Dr. Roshni. Let's. This
Time up.
is we will wrap up this case. My colleagues, according to the new changes in the Viva, you will only have 12 case, 12 case for 1 hour. This is means each case will take about 6 minutes. So, in my opinion, I think it will be extended case. Like this, one CT has many finding and then MRI and complicated. So I bring many of the cases of today like the new updates. You look here, okay, and you start very well. And then you ask for post contrast. No, this is CT. Ask first for bone window. Why? Because here, hyperdensity in the sinuses, you must suspect a fungal sinusitis. Must. When you look here, and this is one mistake you didn't mention, despite I many times go and went, go and come, and you didn't pick up. There are some disruption here. This is invasive sinusitis, my colleagues. Very critical point. Very critical. Invasive fungal sinusitis. Second point, why encephalitis? Give me, see my colleagues, don't restrict yourself in one diagnosis. Give me two and tell me the first is like this and the second is like this. This is okay, this may include encephalitis, okay, but this is finally venous infarction, classic venous infarction, okay? See here in T1, let's see the left, this one, left sigmoid and the left transverse, see? Hyperdense, okay? So we are suspecting first in venous infarction, very classic. Venous infarction is non-territorial, but beside or very near from the site of thrombosis. Then here, restriction. Try to think in your speech. You told me this is a restriction. Most of the encephalitis not restricted like this. Okay, and finally, here you didn't ask about the post contrast. If you didn't ask, the examiner will not give you anything. Ask please. If he refuse, okay, you at least make a trial. Here, compare. This is opacified. This is non-opacified. You pick up the thrombosis here well. So, what is the scenario? There are infection. Here, sinusitis, and what type of sinusitis? Invasive fungal sinusitis, not any type else. And here, there are automastoiditis, very huge brain skull base and the sinuses infection. Honestly, my colleagues, in my opinion, this is an invasive fungal sinusitis involving both maxillary sinus. But in Radiopedia, they mention this is granulomatosis with cholangitis. I'm not sure from their diagnosis, but at least you can tell there are some sinuses. Why I'm not believing their diagnosis? Because the nasal septum is almost intact. This is my opinion, but I'm honestly speaking. See, I revised this case many times. The nasal septum is completely normal, and beside Wagner disease or granulomatosis with cholangitis, huge destruction here, not like this light destruction. Anyway, this is a case also of venous infarction due to infection, either the automastoiditis, almost the cause, and associated with invasive fungal sinusitis. Thank you, Dr. Rishni. Take
Thank you,
care,
sir.
my colleagues, from any notes. This is for benefits of all of us. Candidate 3,
Yes,
are you
sir, I'm
ready?
here. Yes.
Welcome. Welcome. 60 years old male patient presented with headache. Time us, please,
Okay.
Dr. Emmett.
Time started.
Thank you.
Okay, I'm provided with clear images, and I could appreciate extensive flare bright edema signal in the centrum semi-ovale, splenium of corpus callosum, and posterior limb of the internal capsule. So can you show me the T2 images? A similar edema signal is noted. Can I have T1 post-contrast? Okay, there is significant lobulated enhancement in the periventricular region, also involving the splenium of corpus callosum with significant vasogenic edema, and the rest of the brain appears normal. I could not appreciate any abnormality in the infra. In the cerebellum, the paranasal sinuses are clear. I'm looking at the vessels. Can you? Yes, there is thick nodular enhancement in the periventricular region, and it is also crossing the splenium of corpus callosum. So, considering the imaging appearances, my first differential would be of lymphoma. The
What else?
other differential, sorry.
What else?
Yes, the next thing I would be thinking of butterfly glioma. That is the uh,
Okay, what's your next step, please?
I would like to inform the primary physician. I would like to take a neurosurgery consult and send the patient for biopsy. I would like to scan the abdomen to see any abdominal manifestation of lymphoma, or if it's invasive glioma, to see any possible mets. The other things. Yeah, just these are my primary differentials.
What is the name of this
And,
appearance? Could you tell me, please?
and this is butterfly shaped and crossing the
Thank you.
splenium.
Thank
Okay.
you. Could you tell me uh, if this glioma, this butterfly glioma,
Yes.
which grade of
A
gliomas?
high grade 4.
Thank you. 6 years old male patient, lethargy and inability to communicate for more than 1 week.
Okay. I'm provided with MR sequences, T2 images. I could appreciate multiple variable size, well-defined cystic lesions involving the right cerebral hemisphere with significant surrounding vasogenic edema. So could you show me the diffusion restriction? DWI ADC images, please. These are bright on DWI. The center part is bright.
Go
There's
on.
significant there is extension of these things into the right ventricle. Can you scroll down, please? ADC. Yeah, these are showing central diffusion restriction. Can I have post-contrast images, please?
No post contrast. What's your diagnosis, my
I would
doctor?
like to give the differentials. My first differential, considering significant vasogenic edema, would be abscesses, as there is central diffusion restriction. Other possibility of cystic mets appear. I would also like to keep that in differential, but that is less likely because of
What is
the
your first
central diffusion.
differential, please?
First is abscesses, brain abscesses,
Yes.
multiple brain abscesses, and I'm thinking of TB, and I would like to see post contrast, and I would like to inform the primary. I would like to take a neurosurgery consult. I would like to screen the patient. I would like to do a chest X-ray.
Okay. Do you want to do anything else?
Post contrast images.
Okay, you make a diagnosis, but do you want to revise the images for something else? No post contrast available. Do you want to have a look again? to exclude
Yes.
anything in your mind?
Yes. Yes, I'm looking at the paranasal sinuses.
Hmm.
1 minute left.
So can you please scroll downward?
Anything
No,
related, anything important in this
yes, there is.
image?
Yes. There is significant midline shift, and there is herniation of the pars
Yes.
ependymal signal seepage toward other side, and there is what is this called?
What is this?
Midline. There is midline shift.
Okay. What is the name of these herniations? Tell me.
Subfalcine herniation. Subfalcine herniation. And
And what
could you
else?
show me the uncus,
ده
please?
خلاص بقى طارق، ما تقعدش بقى، انا والله من ساعه ما
One
يزول وانا
minute.
نكيت.
Sorry.
1 minute.
I think there is uncus herniation, but I would like to see the temporal lobe.
Time's up.
Here. Thank you.
Okay.
Thank you,
Most welcome.
Doctor. You did very well, but you missed very critical life-saving finding. I was marked you at 9 by 10. In the new system, you will be marked from 100%. 100%. The pass mark is 58%. 58%. Let's see. Let us use the same system. I will give you each candidate a percent in each case. You did very well, and you make a very great diagnosis. And I'm waiting from you the most important. This is abscess. Okay, thank you. But what else? This is very obvious from here. There are marked shift of the midline. And then from the axial, you can get all the informations. And here, this is ankle herniation. See indentation in the right, in the left, in the right side of the midbrain, marked compression, and marked herniation of the ancus. Which ancus? This one, the right one. This is life-saving. It needs urgent decompression, urgent evacuation, urgent neurosurgical intervention. Thank you, doctor. You did very well until, so this is يعني, an advice for all of us. When you see in any examination, try to ask yourself, is there are any life-saving signs? This is very important, my colleagues. Okay?
Okay, sir.
And the other case, so this one is multiple brain abscess. We must ask also if the patient is drug abuser or not, or immunocompromised, because it is very severe infection. In case one, you did very, very well. I give you 90%. But take care, doctor. You waiting me to ask, or you waiting me to shift you to the next step. Second, this is a butterfly-shaped mass centered in the midline of the post-cerebellar hemispheres, and centered in the corpus callosum and crossing to the other side, giving the butterfly. I'm waiting from you to give me this buzzword and extend subependymally bilaterally. You did very well, differential diagnosis, either glioma or lymphoma. This is very high grade astrocytoma or glioma. Also lymphoma, primary lymphoma in AIDS patient, acquired immunodeficiency disease, takes the same butterfly shape. So, but you forget to tell me, I want the sagittal to rule out any CSF drip metastasis, or even the axial drip metastasis, CSF drip metastasis. Check the basal cisterns, my colleagues. Very, very common places for drape metastasis and for granulomatous here around the brainstem here at the surface, the bile surface of the brainstem and the upper cord. Very, very common and very easy place to pick up any CSF drape metastasis here also. Okay, you did very well. Thank you, doctor. Next candidate.
Yes, sir.
55-year-old male patient complaining of weakness and altered sensation.
I am provided with the digital cuts of situated MRI of the cervical spine. The image shows a well-defined intramedullary lesion opposite T2, T3
1 second.
vertebral body.
1 second. I will check something.
Okay.
Yes. Sorry. Go on.
Okay. So there is an intramedullary lesion seen twice the upper part of the cervical cord opposite T2, T3 vertebral bodies, showing the well-defined margins, extramedullary extension, heterogeneously.
Doctor, your voice, your voice is muffled.
Do you
Could
hear
you
me?
raise your voice? Yeah,
Do you
little
hear me?
bit muffled. Increase your
Okay,
voice or talk from
yes,
the directly from the mic because your voice
okay,
is
is it
muffled.
better now? Is it better
Yes,
now?
better now.
Okay,
Yeah,
so
go
an
on.
intramedullary high signal intensity lesion of the upper part of the cervical cord. I would like to see the axial sequence as well, axial sections as well, situated to confirm the intramedullary location. So this lesion is in fact intramedullary in location, causing cord expansion, and it consists of heterogeneous high signal intensity. I want to see T1 weighted sequence to confirm the cystic solid nature of the lesion.
No T1.
And,
No
no
T1. There
T1.
are post contrast.
Okay, post contrast. I want to see T1 post contrast images, please. So on the T1 post contrast image, there is the heterogeneous enhancement of the lesion. So my provisional diagnosis, according to the location, to the length, and to the enhancement, is ependymoma. A second differential diagnosis is astrocytoma. Ependymoma is more likely diagnosis owing to the patient age and to the lesion characteristic. Less likely diagnosis is metastasis.
Could you remember the patient age? Could you remember the patient age?
60 was like
Not 60.
55.
Not 60. Yes,
55. Yes, I said
okay.
55. Yes. Yes, so
Okay.
he's an old age or an adult patient at least.
What is the next step? Or which sequence would do you want to do for the patient?
I want to do the hemo sequence or gradient sequence to look for any blooming, presence of calcification or blood product, especially hemosiderin cap in case of ependymoma.
No hemosiderin.
Okay,
Don't worry about it. What
I
is your
want,
next step?
next step, I want to see request MRI on the lumbar spine as well, and the entire neural axis to look for drip metastasis.
Excellent.
And I want to
Excellent. More than
I
excellent.
want to convey my findings to the neuroradiologist.
This is MRI. This is MRI,
yes,
lumbosacral MRI. Yes.
lumbar, yes. I can see in this sequences that there is a solid lesion opposite the S1 vertebral body that is appearing of low to intermediate signal intensity on T2 in the region of the coda equina.
This is post contrast.
Canal. Yes, and shows enhancement in T1 facet post contrast sequence, likely to be a drip metastasis from the original mass of the upper cervical spine.
What's your final diagnosis?
Final diagnosis is ependymoma with drip metastasis to the sacral coda equina.
Thank you. Case
Thank
number
you.
2 for you.
There is no image yet.
35-year-old female patient complaining of headache and nausea.
I'm provided with the axial cuts of T2-weighted MRI of the brain. I can see that there is an lesion located in the left middle cerebellar peduncle, which is consists. I want first to identify the location of the lesion. It is whether it is intraaxial or extraaxial. It is.
Raise your voice, please, doctor. Raise your voice, please.
I want first to confirm. Yes, I want to confirm the location of the lesion, whether it is intraaxial or extraaxial. I want to check the sequences for the presence
Which
of
sequence you want?
left and the T2 weighted is nice, but I want to see the coronal cuts as well. In addition, yes. Yes, so the lesion is apparently extraaxial, causing indentation of the left middle cerebellar peduncle and cause mass effect and effacement of the fourth ventricle with the displacement of the pons.
What do you which sequence you want
so,
again?
The lesion T1 to confirm the cystic nature of the lesion.
No T1.
T1 post contrast. Okay.
Yes.
So this T1 post contrast image shows
Time is
heterogeneous
up.
enhancement of the
Thank you.
solid parts of the lesion.
What's your diagnosis? Please give me differential.
Schwannoma, cerebellopontine angle lesion, likely to be schwannoma, vestibular schwannoma.
Thank you. Do you want to do anything urgent here? Look here, please. Thank you, doctor. You did very well. This is a case of jugular foramen schwannoma, but you described very well, but you lost one important and the urgent finding. Here there are, like you said, there are cerebropontine heterogeneously enhancing mass lesion. Okay, it is extended down through to the skull base and it exits through one foramen. This foramen located anterior and just posterior to this artery. So this is the jugular foramen and it gave the dumbbell shape. So we are speaking about something related to the jugular. So your differential diagnosis, see, this is the dumbbell. Your differential diagnosis must be within the jugular pathology. You should thinking about jugular schwannoma, paraganglioma, any of them, okay? You did very well, but you described too much in this without telling me two important issues. There are even mild hydrocephalus. Why? I'm sure there are, see, there are prominence. And the most important, look at the fourth ventricle. It is completely compressed. This is an urgent case. See here, complete compression. Okay, and almost supratentorial mild hydrocephalic changes. This is the first point you should talk about. You should tell me, doctor, I will pick up the phone, calling the neurosurgery doctor for decompression or at least for consultation. Okay, so this is jugular foramen schwannoma, heterogeneously enhanced. Second point, you didn't talk about the skull base. You didn't talk about the skull base, and this is one and the most differentiated point between schwannoma and metastasis and lymphoma. You should tell me there are destruction. Whatever you wanted to tell, but at least inform the examiner about your safe procedure. I'm checking about if this aggressive lesion or non-aggressive. Thank you, doctor. You did very well. But again, my colleagues, ask yourself in each case. Number one, is there are any emergency? Is there are any critical results here? Number two, is there are any aggressive nature? This is will increase your mark. The case number one for you, you did it very,
Dr.
very
Akila
well.
is next.
Yes. Hello.
Dr. Akila is next.
Okay, I will explain this case. This case you did very well. You describe it very, very well, and you pick up and asking about the MRI lumbar, and you picked up the metastasis here. Very excellent. But the mistake that you did, you waiting me till I ask you what examination you wanted to do. Okay. By the way, my colleagues, this case was a pilocytic astrocytoma with drop metastasis. Also, the most common in this age, the patient is all elder adult. The most common is ependymoma, but by pathology, it is pilocytic astrocytoma. Not important for the examiner. The most important, in my opinion, in all CNS, including brain or cord tumors, tell the examiner, I want to check drop metastasis. If you are in the brain, tell the examiner, I want to check at least upper cervical, at least. If you are in the cervical, tell the examiner, I want to check dorsal and lumbar. Even you didn't know or you remember this, oh, this tumor cause drop metastasis or not, no problem. No problem, but at least you will prove to the examiner that you are safe radiologist. Next candidate, 45-year-old female patient. Next candidate is ready.
Yes, sir. Assalamu alaikum.
Alaikum salam. By the way, my candidate, sorry, my colleagues, by the way, all of you did very well, but I should comment in each point why I wanted to save you. I want you to يعني, record the highest mark. But really, you did very well, and the hot seat is very stressful. 45-year-old female patient complaining of left-sided hemiplegia, no history of trauma or prior history, surgery or prior surgery.
Okay,
Go on.
I'm presented with the case MRI brain axial cyst flare sequence of a 45-year-old female with left-sided hemiplegia and no prior history of any surgery. I'm looking at the brain and I notice there are multiple areas of high signal intensity involving the right cerebral hemisphere, white matter areas, right cerebral hemisphere in the centrum semi-ovale, and then also in the periventricular region.
Yes.
Yes, and the infratentorial region appears normal.
Look at the skull base, please.
And I can see a
Look.
high signal area in
Yes.
the left, sorry, in the right. I think this is, I have to locate it, whether it's vertebral or I think I can see the carotid in the carotid canal. I see in the carotid canal, but
Yes.
I
Which
suspect
sequence you want? Which
I
sequence?
Can I have a coronal images post contrast?
No,
Or
no,
even
no post contrast. Which,
fat
yes, which fat set?
coronal. Even fat set coronals.
This is T1 without fat set.
Okay, again, the same area is appearing hyper intense.
Give me differential. What's your differential diagnosis?
I think this could represent a vascular insult due to
Yes. Which vascular
this
insult?
um, a dissection, acute dissection, or it could
Yes.
represent leading to these
Dissection.
dissection of the right ICA,
Excellent. Result in
resulting in the vascular ischemic areas in the right cerebral hemisphere. I would like to see the
excellent.
PWI-ADC images and
What will you do next? What will you do next?
I will immediately inform the clinical team and the vascular surgeon and IA team who are available and would evaluate the vessels completely to see the extent and would also suggest
How to
immediate.
confirm this dissection in your department?
Yes, I can do Doppler ultrasound as well, and in MR I can.
Doppler is normal.
I would like to see then cervical MR
Cervical
and
MR.
MRA involving the
कुछ
neck.
नहीं वैसे ही कल से उदासी जी को लिखा तो कॉलेज के मसला हो
Yes, these are the MRA images, coronal view.
Yes. Yes.
Here I can appreciate the left, right-sided.
What happened here? Which type of
Yes.
MRI is this one?
This is, I think, the time of flight image.
Excellent. What happened?
There is a dissection and with double lumen, one, I think, false lumen and true lumen is narrowed. I cannot see, appreciate the intimal flap on these images.
Where? This is the left internal carotid. This is the left ICA. Okay?
Yes. Yes.
Where is the right here? Where is the right? Where is the right here? So give me differential diagnosis, final diagnosis.
I think there is a dissection involving the cervical region of the right ICA, and that's why the distal part is not clearly identified on the
Thank you.
post-contrast.
Thank you. 30 years old male patient presented to the ER after a motor vehicle accident.
Okay, I'm presented with the MR brain of a 30-year-old male who presented with the
1 minute left.
Okay.
Is T1 image, pre-contrast, axial T2 weighted image. These are the flare images. I can appreciate multiple areas of high signal intensity at the mostly they are located in the subcortical region or near the junction of the gray white matter.
Yes.
And I would like this.
This is the diffusion weighted image. What's your differential diagnosis?
These areas showing diffusion restriction. I suspect the top differential would include diffusion axonal injury, diffuse axonal injury.
What else?
And second possibility could be microhemorrhages.
What else?
The patient is young, so I'm keeping the cerebral amyloid angiopathy at the lower down in the list.
This is a trauma patient. Tell me a logic differential. This is a trauma patient. What is the name of this distribution of restriction, foci or restricted foci?
Diffuse axonal injury would be my top differential in this case.
Okay,
In a
what
young
else?
Time's
What
up.
else if thank you. What else if I told you the patient has major pelvic fractures? What are you thinking about?
fat embolism.
Thank you, doctor. Thank you too much. This is a trauma patient, my colleagues. So try to make your differential diagnosis in a logic way. Okay? When you told me this is a diffuse axonal injury, I agree with you. Okay? But don't speak about something chronic or congenital or dismyelinating. Okay? Patient with major pelvic fracture or any fracture make a fat imply showering. This fat imply make this pattern, fat embolism, and this is very characteristic. Please try to train your eye here. This called diffusion weighted stratified pattern, or diffusion weighted star filled pattern. Star filled, like star in the skies. See, scattered, of no predilection. See, this is involving the basal ganglia and subcortical and white matter in everywhere. Why? Because this is epoli. So this is fat embolism. Fat embolism, and this is a medical emergency. Case before, take care, my colleagues, from emergency cases. This is pass or failed. You start very well, our colleague, when you pick up this, and then go and stop many times here. Many times. My colleagues, very important. The skull base is very important. You must get one case with a skull base pathology or the key of the case in the skull base. You must. Why? Because any or most of the skull base pathology either very aggressive or life-saving. Why? Because the skull base involving the vessels or involving a tumoral or a fracture. But I think it is very difficult to give you a fracture here. Okay? This is an aortic dissection, right? Aortic dissection here. What happened? This is the aorta. Sorry. This is ICA, internal carotid. This is right. This is left. Go down, something here. And the patient is trauma. So, there are abnormal signal here. So I must think in vascular injury. Okay? You are asking here, don't ask post contrast before T1 fat set, or at least T1. This is T1. The same, high signal here. See? And it is in the expected location of the ICA. Third, don't leave the patient or the examiner without informing him. The examiner is radiologist. He wants to listen from you about radiology. Ask, I will do MRA. This is the MRA. Compare right with left. This is left, or this is right. Or ICA dissection, you can diagnose it if even the lumen is just narrow. In young patient, in post-traumatic patient, in patient unknown atherosclerotic disease. Why this artery is small? Patient with trauma and has a neurological acute symptoms, think in dissection. See, compare right with left. This is the right, this is the left. There are classification, but this is not important for us. This classification starts from narrowing irregularity, not just complete absence. Here is marked narrowing. Compare, my friends. This is very important case. And if we see here, it is very obvious here. You can see here, the left one, the right, completely interrupted here, and the rest of the right ICA is totally narrowed. The next candidate.
Yes, sir. I'm the next.
Dr. Amir.
Yes, sir.
Welcome. Okay, I will time you. Yeah, let's start. 5.5-year-old female patient, her mother complaining of headache of several months duration of her child.
So I am presented with T2 weighted axial images of a small child. I can see some lobe multilocular cystic lesion in the suprasellar cistern region.
Yes,
Yeah, and the cyst is extending up to the prepontine cistern. I would like to see the diffusion weighted images.
this is a diffusion, but this is p-value 0.
Okay, on diffusion weighted images, I don't see any restricted diffusion. So I can rule out epidermoid cyst by looking at this.
Yes, what else?
Okay, so now I would like to see any post-contrast image if available.
Before any contrast, you want to see any plane, other planes?
Yes, I would like to see the sagittal or cornal. Yeah. Okay. So it is a multilocular cystic lesion in the prepontine cistern and in the supracellular cistern and in the.
Excellent.
I would like to see whether it is extending into the sella or not. It appears to be extending into the sella. No, the sella appears to be normal. Actually, this image is too small, I think. I would like to zoom it.
No, the image
Okay,
is
so
good.
there is a multilocular
Yeah.
cystic lesion with septal enhancement.
Yes.
And there is some enhancing nodule also at superior margin.
Excellent.
So in a
Excellent.
small child, my first differential would be of either a craniopharyngioma.
Yes, if I told you this is T1, what is this? What
Okay,
is the
so
name of
this is
this
fat.
find?
This is fat content within
Not
the
fat,
lesion.
something else.
Okay, so it is a hyperintensity on T1 weighted image, so it could be hemorrhage also
What else?
within the cyst.
Yes. What's your differential first? What's your differential? Hello? Yeah, you
Looking at
told
this
me.
hyperintensity, yeah, my first differential would be craniopharyngioma.
Yes. There are something here in craniopharyngioma.
Is it calcification?
Not calcification.
That would.
Don't worry about it. No problem. Do you want to check something else here in this child or to rule out?
Yeah, I would like to see whether it is encasing the ICAs or not.
Not
For the
encasing
surgical
the
planning.
This is sagittal.
This is corneal flare image.
Oh, see, take this one. Axial.
Axial post contrast. Can I see? Yeah.
Yes.
Okay. Okay.
The
Again, same
ICA
thing.
is
It
fine.
is. Yeah, but
Both
it
are
is
fine.
encasing the basilar artery, I think.
No, don't worry about it. What your next step?
Okay, so I would like to inform the findings to the referring clinician. I would send the patient to neurosurgery MDT.
Yes. Okay.
It's left.